So, as usual, before I start, I like to look at the academic backgrounds of the researchers on researchgate.net because I'm just as interested in the quality of the interpretations as I am of the data collection. 7 out of the 8 researchers are from the Department of Rehabilitation Sciences at the Hong Kong Polytechnic University. Sharon Tsang has a PhD and she is a Fellow of Musculoskeletal Physiotherapy. Her current position is Associate Professor. She has 42 publications, 15,000 reads and 680 citations. Her skills and expertise are neck pain, the spine, neuromuscular control, electromyography, biomechanics, and musculoskeletal manipulations. And I'll just scroll through a couple of her papers, but you can go back and look at those if you're interested. And the second researcher that I found on the team is from the Faculty of Medicine and Health at the University of Sydney in Australia, and that is Alan Fu with a PhD, an MSc in Sports Medicine and Health Science, a postgraduate diploma in acupuncture, and a bachelor's with honours in physiotherapy. 23 publications, 4,500 reads and 257 citations. He's a lecturer at the University of Sydney in the physiotherapy department, and his skills and expertise are sports injuries, biomechanics and acupuncture. These are the publications. I won't go through them all. So I'm confident, even from these two researchers, that I will get a high quality interpretation of the results of this paper, which always makes for a very good discussion. So as I said, the other researchers I cannot seem to find as listed on ResearchGate, but I have had a look at the Hong Kong Polytechnic website, and they have a brochure there that you can download with all of the detailed backgrounds and skills and expertise from their resident research team and lecturers. This scientific paper was not produced by an equitation research team, but it highlights an equitation issue, that of the effects of the degree of spinal curve and pelvic tilt in riders. The ideal equitation posture is to align the ear, shoulder, hip joint and heel when viewed from the side, but this does not take habitual abnormal spinal curvature into account. And for those riders aiming to sit in this shoulder hip heel alignment, they would benefit from considering their spinal curvature lying between those points to avoid spinal dysfunction and pain. Abstract. Promoting an erect posture in standing, also referred to as a neutral posture, has been advocated to offer superior protection to the spine when compared to hyperlordotic and swayback postures. The research question was, do postural adjustments towards external perturbation differ between erect, hyperlordotic and swayback postures? If so, which posture offers better protection to the lumbar spine? Method 44. Healthy adults received top-down vertical perturbations under unpredictable, that is without visual and auditory input, versus predictable with visual and auditory input conditions in those 3 simulated postures. Postural adjustments, namely the center of pressure parameters, joint angle onsets, and neuromuscular responses measured by muscle onsets and co-contraction between muscle pairs, were compared using 2-way repeated measures ANOVA. A further statistical test identified the between posture differences for the respective postural adjustment parameters. And the results? Path lengths, ellipse area, and average velocity of centre of pressure were significantly greater under unpredictable conditions as compared to predictable conditions. Significant between posture difference was detected in centre of pressure path length, pelvic tilt onset, and all muscle co-contraction indexes. Further statistical analysis revealed significantly smaller centre of pressure path length in erect posture as compared to hyperlordotic and swayback postures under unpredictable conditions. Significantly greater co-contraction indexes of the lumbar multifidus and erector spinae muscles and internal oblique and lumbar multifidus were found in hyperlordotic postures when compared. And the significance is that the adoption of hyperlordotic and swayback postures altered the contributions of the active and passive subsystems of the spine that regulate postural control initiated by perturbations. And these differences may lessen the capacity of the human spine to withstand loading and shear forces. But further study is required to validate if habitually adopted hyperlordotic and swayback postures contribute to an earlier or higher prevalence of spinal dysfunctions. Introduction. In daily functional tasks such as lifting and walking, both internal and external perturbations require the body to effectively maintain stability, achieved through coordination of various postural adjustment strategies. Neuromuscular adaptations leading to modulation of muscle activity and or postural change are the fundamental component to all adjustment responses to perturbation. One of these adaptations is direction-specific response, expressed as coactivation between muscles that share similar functional roles upon multi-directional perturbations. Onset timing of muscle activity indicates the sensitivity of the active motor control system. And these adaptations are specific and objective measures to assess the two major strategies of postural adjustments, which are anticipatory postural adjustments and compensatory postural adjustments. APAs are the feed-forward strategies where the adjustment starts before a predictable postural perturbation, and in contrast, CPAs are regulated by feedback from either predicted or unpredicted perturbations. Different coupling and timing of these two mechanisms contribute to various postural responses. Therefore, temporal or timing analysis of neuromuscular adaptations should be applied to reveal the contributions and effectiveness of the postural control strategy. Multiple factors, such as visual and auditory input, proprioception, and habitual posture adoption, influence the effectiveness and preferential strategies of the postural adjustment. It's been shown that increased APAs and decreased CPAs in response to predictable perturbation, while the absence of APAs and greater involvement of CPAs were identified during unpredictable conditions, confirming the influence of visual and auditory input on choosing the strategy. Impaired proprioception, on the other hand, is thought to result in compromised muscle activity for the reduced sensory input, leading to muscle atrophy and fatty infiltration. So what this means is that spinal muscle dysfunction reduces sensory input, which in the longer term leads to muscle wasting and infiltration of fat into the muscle, so that weak and altered muscle composition reduces function. Two common poor postures are sway back and hyperlordosis. Sway back is the flattening of the lumbar spine with posterior pelvic tilt, hyperextended hip and knee joints, with a neutral ankle position. Hyperlordosis is the increased lumbar lordosis with anterior pelvic tilt and hip flexion, slightly hyperextended knee joints and plantar flexed ankle joints. There is a significant increase in activity of rectus abdominis, but a decrease in internal oblique, lumbar multifidus and erector spinae muscles found in sway back. These muscle recruitment patterns imply an overall reduction in contribution of the active subsystem of spinal stability in passive postures. Meanwhile, the extended lordotic and anterior pelvic tilting position in standing with hyperlordosis was demonstrated to alter the spinal biomechanics and muscle length characterized by overactivity of the lumbar erector spinae and underactivity of the internal obliques. Ultimately, the protection to the spine from external loads and the efficiency of the subsequent postural adjustments will be affected. This study aimed to compare the differences in postural adjustments in response to predictable and unpredictable perturbations between erect posture, sway back, and hyperlordotic postures. Hypothesis 1. A more effective response to predictable perturbation will be observed when compared to unpredictable conditions. And 2. The erect posture is a more effective posture in response to external perturbations when compared to hyperlordotic and sway back postures. Participants were healthy adults above the age of 18, recruited from a university community. Individuals were excluded if they had a history of spinal pain requiring medical treatment in the past 6 months, and this was to control for any postural dysfunction, degenerative or chronic spinal conditions, structural spinal deformity or scoliosis, leg length discrepancy, history of orthopedic surgery or pregnancy. Sample size of 45, had been previously validated during an arm loading task between healthy and back pain individuals. And figure 1 shows the experimental procedures, which were stage 1, screening the participants, postural assessment, perturbation trials in 3 conditions of 3 postures and 3 trials for each posture under predictable and unpredictable conditions. So erect, hyperlordotic, sway back, each performed in 2 conditions of predictable and unpredictable. And they used electromyographic activity testing together with balance and postural assessment. 3 data sets were excluded due to poor quality, and then they analysed data from 44 participants. The experimental procedures: surface topography to assess the habitual posture of the participants with 8 reflective markers being placed at bilateral posterior superior iliac spines on the pelvis and over C7, T3, T6, T9, T12 and L3 spinous processes to generate light patterns projected for 6 seconds. A 3-dimensional spinal model was reconstructed to quantify the lordotic angle of each participant based on the surface tangents between the thoracolumbar landmarks, T12 and L3, and lumbosacral inflection points, which were the bilateral posterior superior iliac spines. Muscle activity and kinematics, they used EMG of 7 lumbopelvic muscles bilaterally on both sides, based on the electrode placements of lumbar erector spinae, multifidus, gluteus maximus, biceps femoris, rectus abdominis, internal oblique, and tensor fascia lata. And they also used inertial measurement unit sensors, or IMU sensors, at the external occipital protuberance, T1, T12, S1, midway of the bilateral thighs, and the midway of the left arm and forearm. Postural simulation and perturbation trials. There is no absolute consensus on the definition of sagittal spinal alignment. Therefore, the 3 simulated postures were defined according to the best available references. Here, participants stood on a force plate and held a container in 90-degree elbow flexion. Postural sway was measured as the indicator of the global postural adjustment. A weight of 1.5% of body weight was released into the container held by the participants to create the top-down perturbation. So bear in mind that for horse riders, it's the opposite, from below vertically upwards. And they had to maintain the elbow angles. They were positioned into 3 simulated postures in a randomized order. There were 3 trials under a predictable condition with both visual and auditory inputs made available to them as the load was released, and another 3 trials under unpredictable condition in which they were blindfolded with no auditory input. EMG, muscle onset and co-contraction index were identified with software, and the root mean square envelopes were extracted. And that refers to the pattern, the 2-dimensional pattern which is made as the centre of mass moves around the centre of pressure. Positive and negative values suggest muscle activation after and before perturbation, respectively, and these are represented in graphs which detect the onset of the muscle activation and lumbopelvic movements in response to the top-down anterior perturbation. So at the point of impact, which is this pink line, the elbow angle changes and muscle activity occurs. There is, of course, in the postural muscles, in standing, so the trunk and leg muscles, to maintain a standing posture. And you can see some residual muscle activity, right biceps femoris, right gluteus maximus, and right multifidus. So some muscular asymmetry there, or limb dominance. And they applied a control measure of ensuring that the onset was determined accurately and that voluntary movements were not mistaken as response to perturbation by the software. This perturbation was delivered in the sagittal plane, and the co-contraction index was calculated according to previously validated techniques, which was here. Kinematics, the joint angles, left elbow flexion, lumbar flexion, pelvic tilt angle variations against time were selected for analysis. So these were upper body joint angles, even though they also measured the lower limb. And this was defined and identified as the time when the instantaneous changing rate of the corresponding joint angle exceed 6 standard deviations from its baseline measurement. So here, and they've illustrated lumbopelvic movements. So looking at the pink line at the point of perturbation, we can see how the angles changed. So more or increased lumbar flexion and initially decreased pelvic tilt, but recovering. And the data was processed by software. Postural sway, center of pressure path length refers to the antero-posterior excursion or displacement during the perturbation trials. COP ellipse area quantifies 95% of the total area covered in the anterior posterior and medial lateral direction with an ellipse, again previously validated. The COP average velocity was calculated by dividing the COP displacement by time during the trials, again validated. So they've used an accepted system for measuring and determining postural sway. Statistical analysis, two-way repeated measures, ANOVA, comparing centre of pressure path length, ellipse area, velocity, joint angle onsets, muscle onsets, and the co-contraction indexes across the two conditions and three postures, and t-tests to determine which comparisons was or were significant, if a significant difference among postures was detected in the ANOVA. In other words, they will select the meaningful data to discuss. And the results, there are 3 sites of co-contraction and 2 conditions, unpredictable and predictable, across 3 postural positions. The average lordotic angle of the participants was 36.47 degrees, 10.49 degrees, with the 95% confident intervals of 34.2 degrees and 40.2 degrees when their habitual postures were assessed by the surface tomography. Centre of pressure parameters, path length, ellipse area and average velocity were significantly greater in the unpredictable condition, which is logical, because it would take a high degree of conscious postural control to anticipate postural perturbation, but only centre of pressure path length demonstrated a significant difference between postures, which later revealed a significantly greater centre of pressure path length in swayback posture. For the predictable condition, no significant between posture difference in COP path length was found. So this demonstrates that when participants knew that the perturbation was going to occur, they could prepare for it intrinsically. So greater path length, ellipse and velocity in the unpredictable conditions compared with the predictable. Joint angle onset, lumbar flexion and pelvic tilt were significantly later in predictable condition compared to unpredictable condition. And this shows that when the subject is aware of an impending perturbation, they're slower to react. But there was a significant between posture difference found in onset of pelvic tilt, but not lumbar flexion onset. And this means that across the 3 postures, there was a difference in the onset of pelvic tilt, which wasn't followed through to the lumbar. Post hoc analysis, significantly earlier pelvic tilt onset in sway-back posture. So this means that when the body's centre of mass is already behind the centre of pressure, this will trigger pelvic tilt in the unpredictable conditions. But no significant difference was found in predictable conditions. Neither lumbar flexion nor pelvic tilt showed significant condition and posture interaction effect. And this will be explained in the discussion. Muscle onset, there were significant between condition differences in onsets of gluteus medius, biceps femoris, and internal obliques. Onsets of erector spinae and biceps femoris have significant between posture differences. Figure 4. And the asterisk indicates between condition difference. So lumbar flexion, pelvic tilt, internal oblique, biceps femoris, gluteus maximus, and the star indicates between posture difference. Pelvic tilt, biceps femoris, erector spinae, across the 3 conditions. And this finding will be discussed and explained in the discussion phase. Post hoc, statistically insignificant results for erector spinae onset in all comparisons between postures under both unpredictable and predictable conditions. Regarding biceps femoris, significantly later onsets in hyperlordotic posture were found in comparison to the other postures in both conditions. And the condition and posture interaction effects were insignificant in all muscles. Co-contraction index, no significant between condition difference found in co-contraction indexes for all muscle pairings. The indexes were significantly different between postures in the internal oblique multifidus, rectus abdominis, erector spinae, and multifidus erector spinae pairings. In the unpredictable condition, post hoc analysis, significantly higher co-contraction indexes in hyperlordotic posture in the multifidus erector spinae and internal oblique multifidus pairings. Significantly higher co-contraction indexes in erect posture compared to sway-back posture were discovered in rectus abdominis, erector spinae, and the internal oblique and multifidus pairings. Between the hyperlordotic and sway-back postures, significantly higher co-contraction indexes in the hyperlordotic posture were detected in multifidus erector spinae, rectus abdominis erector spinae, and internal oblique multifidus pairings. So this is a little muddling as they state the postural events or strategy, but it will be explained later. Because obviously we just need a summary of the findings, and sometimes they are challenging to get your head round and process. In the predictable condition, so with the visual and auditory cues, significantly higher co-contraction indexes in hyperlordotic posture compared to erect posture were observed in multifidus erector spinae and internal oblique multifidus pairings. Significantly higher co-contraction indexes in erect posture compared to sway-back posture were discovered in rectus abdominis, erector spinae, and internal oblique and multifidus pairings. So we've got some detailed information here. Not only are they reporting postural changes, but they are indicating which muscles were involved. in the postural strategy. In addition, significantly higher co-contraction indexes in hyperlordotic posture compared to swayback posture, so the two abnormal postures, were detected in multifidus erectus spinae and rectus abdominis erectus spinae and internal oblique and multifidus pairings. So the co-contraction index, this looks more complicated than it is. It's just how it must be described as results. Discussion, what we've all been waiting for. Results confirm that a more effective response to perturbation was displayed under predictable conditions compared to unpredictable conditions. That's fairly logical. When you see a perturbation is about to impact, you can strategize to prepare for it. Erect posture is found to be superior towards external perturbations for its greater effectiveness in postural adjustments, substantiated by the consistently lower center of pressure measurements. The differential responses were observed in the onset of lumbopelvic muscles. And for the rider, this means that a shoulder, hip, heel posture is superior, but only if the lumbar spinal alignment is also erect or neutral. The differential responses were observed in the onset of lumbopelvic muscles and synergistic contraction between the deep and superficial muscles of the lumbar spine. And this is what they were referring to in their EMG measurements. They've differentiated between deep and superficial muscles of the lumbar spine. Under the load transfer and dissipation mechanisms of the spine, greatest axial compressive force at L5-S1 would be expected, as those segments serve as the primary shock absorbing ones when one holds an external load. So can we consider that that's comparable for the forces from the horse's movement that is directed at the rider? I think it could be greater because the rider's pelvis is contacting the saddle and there is the potential for leverage there. Therefore, the earlier onset of the anterior pelvic tilt movement observed in swayback in the unpredictable trials indicates the potentially inefficient force dissipation at the lumbopelvic region towards perturbation for swayback posture adoption. So, unpacking this a little, the swayback posture is an inefficient force dissipator at the lumbopelvic region in unpredictable trials. The role of lumbopelvic muscles at the active spine stabilization strategy. Force dissipation in this region is mediated by muscles which can essentially be classified into two groups: deep local, which are the internal obliques and multifidus, and superficial paraspinal muscles, rectus abdominis and erectus spinae. It may have been less of a challenge to read and mentally process the results if we had been told that earlier. There's so much detail here. I certainly would have expected that to have been stated in the introduction because they're making a case for postural strategy. And this is important. Our findings exemplify the dual roles of both erectus spinae and rectus abdominis in stabilization and balance restoration during predictable perturbations for the co-contraction pattern of rectus abdominis and erectus spinae, and are comparable to that of erectus spinae and the multifidus pairing, which is a deep local muscle pair across all postures under predictable condition. So that means the superficial paraspinal muscles have a dual role in stabilization and balance restoration when perturbation is predictable, and is comparable to that of the deep local muscle pair across all postures under the predictable condition. And to unpack that, the superficial paraspinal muscles have a dual role in stabilization and balance restoration and are comparable to that of the deep local muscles across all postures when perturbation is predictable. Rectus abdominis contributes to lumbopelvic stability by preventing the pelvis from lateral or anterior rotation, and that's from the side or to the front during movements, while erectus spinae counteracts the bending movement and anterior shear forces acting on the lumbar spine. So they've defined a functional role for these muscles with their results and evidenced flexion and shear forces that act on the lumbar spine. And by referring to the co-contraction of multifidus and erectus spinae, we can examine the capacity of the lumbar spine in counteracting the flexion torque, or the rotational force, generated by the top-down, vertical, perturbation procedure, the trials, adopted in this study. The higher co-contraction index between local and global muscles, the greater the spinal protection. So again, they're evidencing muscle function, co-contraction, and its protective value. But overactivation of superficial muscle is considered as a sign of altered neuromuscular control in people with low back pain. And what that means is that low back pain has been found to alter neuromuscular control due to overactivation. And the extent of increased muscle activity of erectus spinae was relatively low when compared to the 20% of maximal voluntary contraction of the lumbar erectus spinae elicited by the top-down perturbation using a 6.8 kilo load reported previously compared to the lower load that they used in this study. They've identified that the internal oblique and multifidus, the deep local muscles, serve as the primary stabilizers of the lumbar spine for their consistent activation, irrespective to the perturbation conditions. So this now makes a case for maintaining optimal function of those deep local muscles. With the significant difference found in the co-contraction index of the pairing between local and global muscle among the three postures, post hoc analysis reveals the consistently lower co-contraction of the muscle pairs, which were the deep local muscles and the superficial paraspinal muscles in sway back trials. And this they interpret as indisputably reinforcing that the sway back posture is the least ideal posture to be adopted for its ineffectiveness found in maintaining lumbar stability through the engagement of the muscle system. So this means that the sway back posture somehow inhibits the maintenance of lumbar spinal stability on a muscular level. Muscle activation under predictable and unpredictable conditions. Variation in muscle activation timing may explain the significantly greater postural sway and earlier joint angle onsets in unpredictable conditions. No significant difference was found in the onset of erectus spinae and multifidus, irrespective to the perturbation, and the finding for erectus spinae is consistent with a previous study. So when you're carrying out these investigations, it's important for the results to corroborate with previous research findings. because it strengthens the argument and the interpretation of your results. But both gluteus medius and biceps femoris, which activated significantly earlier in unpredictable condition, so those are the lower limb muscles, could possibly represent a compensatory strategy for the earlier onsets of both the lumbar flexion and pelvic tilt. So that's plausible because it shows that these lower limb muscles are activated in unpredictable perturbation to compensate for lumbar flexion and pelvic tilt, to prevent falls and resultant injury. Previous study, the central nervous system optimizes the role and function of anticipatory postural adjustments when they are available by scaling down the compensatory postural adjustments. And other researchers hypothesized that the compensatory muscle activations could be related to the anticipatory postural adjustments insufficiency, which was supported by the findings in young children. The body is hardwired to produce locomotion, even if it means imperfect gait. The fact that the body can put a compensatory postural strategy in place is impressive. And when young children are learning postural skills, the learning of the mechanisms is much more exaggerated as they learn by their mistakes, which is why they're fascinating to watch when they're learning how to move independently of assistance and the furniture. In the absence of anticipatory postural adjustments under unpredictable condition, the early activations of gluteus maximus and biceps femoris observed hereby suggests compensatory postural adjustment occurred at the hip joints for possibly inefficacy of the postural control strategies of the spine in withstanding the unpredictable perturbations, which was evidenced by the greater postural sway measured by the center of pressure parameters. That must be the longest sentence I've ever seen in a research paper. So let's unpack that. When there was no opportunity for anticipating postural adjustment, the lower limb muscles compensated around the hip joints, because those muscles cross the hip joints, to withstand the unpredictable perturbations, which were evidenced by greater postural sway. Unfavorable effects of hyperlordotic posture on active and passive subsystems. So this paper is really quite impressive because they're going a long way towards evidencing postural control. And this is what we need more of in equitation, not just to study what expert or skilled riders do, how they ride, how they support themselves on a horse, but what that mechanism of control is in relation to processing or distributing the forces directed at them from below from the horse's movement. All the co-contraction indexes, except for the erectus abdominis and erectus spinae pairing, are significantly higher in the hyperlordotic posture compared to the erect posture in unpredictable conditions. And a higher co-contraction pattern between all muscle pairs was revealed in hyperlordotic posture trials, regardless of the primary role of the muscles. So again, they indicate that the hyperlordotic posture is ineffective, and that both the deep stabilizing muscles and the global muscles co-contracted to maintain the exaggerated lordosis. So let's clarify. The deep stabilizing muscles of the trunk and the global muscles of the posterior and anterior trunk co-contracted to maintain the exaggerated lordosis. Prolonged contraction related to lack of condition-specific activation could result in muscle fatigue, and it leads to impaired neuromuscular control and capability to generate force. So this is a very important interpretation here, because they're advocating that the shortcomings of the lordotic lumbar spine is due to the residual prolonged contraction to support and maintain that postural deviation, which is fatiguing and in turn disrupts neuromuscular control and the ability to generate force. And while force generating capability of muscle decreases, the cortical control over the active and neural subsystems also decreases, which corroborates with an earlier study. So again, this is another reason why the rider's back muscles should be well conditioned to dissipate the harmful forces generated by the horse's movement. But more importantly, fatigued muscles are less likely to maintain its proprioceptive accuracy. And this is why saddle construction is very important for the rider, because pelvic floor support, or sufficient support, means that the associated muscles do not fatigue, or that the muscles are slower to fatigue. And this is why riders need to build endurance into their spinal muscles, not to necessarily maintain a flexion extension movement, because I don't believe that's healthy for riders' spinal health, but for proprioceptive accuracy. The ability of the muscles to respond to sudden loading, thinking of those riders who jump their horses, may therefore be compromised under hyperlordotic posture. So what the suggestion seems to be is that if you ride in a discipline where you are aware that the lumbar spine is under load and you have a lordotic spinal curve, this needs to be professionally evaluated and addressed. The additional compressive load associated with the hyperlordosis, and remember they stated that the loading occurs at the lumbosacral joint L5-S1, may potentially increase the risk of joint pathology and degeneration. So although those pathologies are not typically seen in riders as much as you would expect, and in my own research I found that rider pain is typically moderate, intermittent and without changing, it could be that the rider spine doesn't quite make it to the pathological state, but that doesn't mean that their pain should be disregarded. And I think it's relevant to also add in here that horse riding is used in hippotherapy, so that horse riders are plausibly receiving a hippotherapy treatment every time they ride to mitigate the effects of spinal pathology potentially. But the fact that there is pain present suggests that the body is responding to some form of dysfunction. Our results showed some emerging evidence to suggest that both active and passive subsystems, when adopting a hyperlordotic posture, could potentially be suboptimal for protecting the spine from external perturbations. And there you have it. It's worth pointing out here that females tend to have 4 degrees more of curve compared with males, so they can be predisposed to dysfunction and pathology in the lumbosacral region. But the message here is that a hyperlordotic posture is a postural red flag when the spine is under load. Limitations. Interpret with care because the participants were young and healthy individuals, and only the flexion torque was induced in our top-down perturbation procedure. In other words, it's not every day that you have to stand there with a box waiting for a weight to be dropped in it. So they're questioning the extent of how much these findings transfer to the general population and their everyday activities. But once you put all this in context and consider other research, and for our purposes, equitation research, all these little parts of the jigsaw make up the big picture and help us to understand the mechanism of postural control, even though it may not be just gluteus medius and biceps femoris involved in protecting the lumbar spine of the seated rider, but it's nevertheless very high quality information that's generated from outside of equitation research, because the research in the general population has been going on for a lot longer than in equitation research. And finally, it was the set of simulated postures, but not the naturally adopted posture of the participants being examined. Yes, to increase the robustness of their control of the variables, they used repeated measures. So they asked the participants to adopt a lordotic and sway back posture and neutral. So this would not necessarily have been representative of that posture when it is residually represented in individuals who already have a lordotic, sway back or erect posture. So they would have to activate muscles to produce those postures. So what you gain in control, perhaps you lose in the accuracy of the results. But they've nevertheless pointed that out. So as a researcher, control is a very important aspect of experimentation. So there's a balance to be struck between control and between the accuracy of your results. And this is what happens when you use a convenient sample rather than actual examples of individuals or participants who have the variables that you are testing. And they say generalization of our results to other population or to different form of perturbation should not be recommended. But they've nevertheless done a very good job of measuring it or validating a measurement protocol. Conclusion, our findings revealed that both swayback and hyperlordotic posture resulted in a different postural adjustment strategy when compared to the erect posture. So there's something going on with the posture when there are deviations in the lumbar spine. And this impacts on potential spinal health. Future studies, they suggest perturbations from other directions and prospective longitudinal studies to investigate if naturally adopted hyperlordotic and swayback postures contribute to neuromuscular impairment and development of spinal disorders. So they've recognised the limitations and some applicability, and their next step is to investigate with participants who habitually adopt the 3 postural conformations. To summarise, this very high quality detailed research paper from the field of human rehabilitation, produced by 8 researchers, investigated postural stability across 3 postural conformations and 2 conditions of predictable and unpredictable perturbations in the static posture. The 3 postures were simulated as part of a repeated measures design with high levels of control, except that simulation of exaggerated, non-habitual postural positions for the individual participants may not have represented the true states of postural deviation under test. Muscle activation was measured together with postural sway, joint angle, and velocity to determine the robustness of postural stability. Results highlighted the function of leg muscles to stabilize the lumbopelvic region and established trunk muscle co-contraction strategy to support the lumbar spine when posture was less than ideal, i.e. in the swayback and hyperlordotic conditions. This co-contraction strategy pointed to the potential for fatigue in those muscles to increase the potential for low back pain and dysfunction. Although this study directed perturbation force originating from above the participants, who had to resist postural displacement, and therefore may not be representative of riding a horse, it nevertheless highlights the importance of optimal postural alignment. The equitation postural preference of maintaining shoulder, hip, and heel vertical alignment should have their lumbar spine conformation taken into account to prevent low back dysfunction. And this is particularly important when perturbations are unpredictable.